Thank you, Amy. Thank you to you and to Gilda's Club for this opportunity for me to share my experience with this important subject that many of my patients um, um, suffer and continue to experience and suffer from. Um, uh, Without further delay, I'll go ahead and get started. Our talk today is about Chemobrain. Uh, Many of you are familiar with this term. Chemo fog is another um, description. There are some more sophisticated terminology and definitions that we will go over with. And I will also share with you some of the symptoms that we really learn from patients, what they're telling us, what they're experiencing. And that leads our further investigation into more details and deep dive into what leads to those manifestations of this important syndrome. We will go over causes behind it and then how do we address it in terms of trying to prevent it in the first place and then try to manage it and treat it and help patients through their journey with Chemobrain. I'll start with a case, and this represents probably one of the more common patients being touched by Chemobrain, but certainly not exclusively so. This syndrome can be experienced by any cancer patient, including sometimes patients who've never actually received chemotherapy. This particular woman is a 62-year-old who had early breast cancer that it wasn't really metastasized, but was enough of a high risk to warrant chemotherapy administration even before planned surgical removal of the breast tumor. And chemotherapy for breast cancer is not easy. I don't know if any women with past history of breast cancer are with us or listening to this talk. But chemotherapy for breast cancer is difficult and quite demanding and taxing on the body and mind. And it's also lengthy. Many times it takes more than a few months to finish treatment. Some treatments go for a year or even more if you include hormonal therapy, such as what this patient received. The drugs this patient received are common breast cancer drugs that have been around for quite some time. Adriamycin was started to be implemented in breast cancer treatment back in the mid-80s. Cyclophosphamide also for even since the 70s, we've been using it for early breast cancers. Taxol was introduced later in early 2000. Following this successful treatment, where the tumor did shrink, the patient underwent resection of the cancer. She also had her contralateral breast removed as well. And because of the features of the cancer, she did receive radiation therapy, excuse me, to the breast and axilla. And then following that, this particular tumor expressed the estrogen receptors, and the patient was advised to receive anti-hormone therapy as part of her treatment. So this patient experienced during, excuse me, I have allergies trying to get over those, so pardon my cough here and there. Uh, uh, she continued to experience symptoms during chemotherapy administration, and those ranged from the nausea that some patients experience to fatigue, but also other symptoms, including emotional disturbance, some depression symptoms, anxiety symptoms. And as the treatment with the chemotherapy was completed after 5 months, the patient continued to experience not being herself. This is a phrase I hear not infrequently. So certain basically phrases that patients share with us, cancer docs. I can't find the right words when I'm having a conversation. I forget what I wanted to say by the time the other person finishes talking. Sometimes my patients tell me, By the end of my sentence, I forget to say what I wanted to say in the first place. I feel like I'm in a fog. I cannot concentrate anymore. I feel tired all the time. Those are common recurring phrases that we hear from patients. I don't know if any of you are Tilda Swinton's fans, but in a recent movie by Tilda, she plays the role of a cancer patient who has been receiving chemotherapy, and those are some of the sentences shared in this movie. My memory keeps failing me, and I get distracted so easily. She has been a writer and a war correspondent before her diagnosis. The doctors say I have Chemobrain, and it can continue even after the treatment stops, and it can go on for years. I can't trust my judgment about anything anymore. Profound statements that really reflect the reality of this Chemobrain, chemofog patients report. So, what is the syndrome of Chemobrain? We can narrow it down to make it fit in this slide, but it's really a very broad manifestation that describes cognitive difficulties. Many times they're mild to moderate. They do not, for example, include motor dysfunction, which that would be a stroke symptom, for example. So those are really limited to cognitive dysfunction. The most pronounced manifestation of which include difficulty with memory, usually short-term memory, difficulty with concentration, carrying on a conversation, and that occurs in patients, in individuals who are currently receiving or have received chemotherapy treatment in the past. It becomes difficult for those individuals to recall basically things they've heard from others. They have trouble also recalling things they have seen. They have trouble remembering things, remembering words and phrases and images. They also can report difficulty with short-term memory where they forgot, for example, where they were going, what they were doing. It can be, pretty serious impact on their flow of daily life. It also interferes with patients' thinking ability. Uh, uh, Many of those patients used to multitask very effectively before their cancer diagnosis and starting chemotherapy. Now they have really difficult time doing more than one thing at a time. They're slower doing these tasks. They are slower to learn new skills. After taking time off work, when they try to go back in, they report difficulty getting back up to speed to the same level they were before having that interruption of their work life, for example. They tend to have short attention lifespan, and those routine tasks, whether it's at home or at work, they're taking longer than they used to. Is this common? It's quite common. Different studies have reported on Chemobrain. This started to become a recognized issue since the 70s, and it was really led most of the advocacy, the research happened in women with breast cancer. But by no means this phenomena is limited to breast cancer diagnosis. So since the 70s through the 80s and beyond, reports and larger scale studies have touched on this issue at different levels. And the prevalence really have a wide range from 20 to 80%. Most would agree that 1 in 3 breast cancer survivors would report clinically significant cognitive impairment is on the conservative side. There are different ways to report those particular impairment. They can be subjective reporting. and that usually is a much higher prevalence compared to objective, basically description of those cognitive impairment by certain testing, short cognitive screening tools, and neuropsychological testing, which by those more rigorous methods of testing individuals, the prevalence from a multi-analysis report is about 1 in 5. The duration of Chemobrain varies also. In most individuals who are affected, they tend to report complete or near complete resolution by 1, 2, or maybe 3 years. But some patients do report continued deficits, and they're never back to normal 20 years and beyond. The good news is most people would report going back to reasonably normal quality of life and cognitive function by 3 to 5 years. So what causes Chemobrain? We will go into that in detail. Obviously, those patients have cancer diagnosis, and many of them have received cancer treatments. Chemotherapy can directly cause toxicity to the brain tissue. Radiation to the brain also can contribute in a big way to cognitive impairment. Additional cancer treatments also carry a role. Hormonal therapy certainly is associated with cognitive decline and symptoms that patients report. And then there are newer cancer treatments that many of the patients now are receiving, ranging from immunotherapy to targeted therapy. And those are still very fresh and new, and we don't have enough reports to link it to cognitive decline. The underlying pathophysiology includes some inflammation to the nerve tissue in the brain, and there have been documented brain changes at the anatomic level where we see neuron degradation and demyelination of the conductive system in the brain. So there is a cancer underlying diagnosis, and then in many of those patients there is chemotherapy contributing to the cognitive decline, and that happens through multiple levels. Cancer itself leads to an inflammatory state in the body, as the body is being somehow tipped by the cancer into secreting certain pro-inflammatory cytokines. They can have direct damage on the brain tissue. Cancer itself can cause direct neurotoxicity by, for example, spreading to the brain tissue. And then many of cancer patients are older, and certainly getting older has its own associations with cognitive decline. Having cancer on top of it would just make matters much, much worse. Chemotherapy can also, in addition, lead to certain methylation, which leads to damage of the neurons. And there's oxidative stress from chemotherapy drugs themselves. Addressing those particular mechanisms of brain injury can lead to identifying some treatments to address those findings. Antioxidants really come on top of the list as particular substances. Many of them are available through diet or natural supplements, and they can help with repair or preventing damage to the brain tissue. Diet has a big role also through getting antioxidants through diet, limiting blood sugar, having enough healthy fats and vitamin D, and also physical activity and stress reduction mechanisms. Amy just mentioned, for example, a few Gilda's Club functions that can help quite a bit in this regard. And here is also another look at the pathophysiology behind Chemobrain, those inflammatory cytokines or methylation changes that can lead to damage to the brain tissue. Cancer itself is associated with apoptosis and autophagy, and that contributes to death of the brain cells. There is different description to Chemobrain in the scientific community. So some people have adopted the term chemotherapy-induced cognitive impairment. Others use a different term, chemotherapy-related. I think the direct association between chemotherapy and cognitive impairment can be clearly concluded from studies that were conducted both in patients and also in subclinical models. There is reduced neurotransmitters, which lead to slowing of conduction in the brain tissue, and multiple dysregulation, including MAP kinase. Those are different chemotherapy drugs, and if you recall what our patient received, three of the drugs that are on this list were received by this patient. Another one is methotrexate that tends to, in high doses, crosses the blood-brain barrier and also contributes to damage to the neurons, and you have neuronal cell death. There's also damage to the basically axons and damage to the myelin that coats those neuronal cell to neuronal cell endings, and damage to that leads to slowing of the conduction in a big way. So we hear patients describing that those symptoms of cognitive decline, it's taking them more time to do things. It's taking them more time to remember things and the forgetfulness that comes with it. So do we have anything objective to actually listen to the patient and then do some form of a blood test or a picture and see that reflecting on their body? And indeed we do. So the MRI technology has been developing over the past decades and used very frequently now. Here I show a picture to a patient who received high-dose methotrexate, and this is a normal brain here on the right, and you can clearly see the stark difference where this high-dose methotrexate resulted in changes to the white matter right here, and that has all of those basically highways that neurotransmission happens through, and damage to that can be associated with chemobrain symptoms, including slowness in thinking and memory issues. This is another study with different technology many of you are familiar with. That's PET scan. So PET scan is a functional study. They inject patients with sugar containing dye, and areas of metabolic activity will appear on those pictures in red, orange or red, while areas that doesn't have as much activity will be colder, so green or blue. And they took in this study about 15 patients, and they had also controls matching for age. And they asked those patients and volunteers to perform certain tasks that have to do with memory. And as those individuals were doing this, they took PET images of their brain. And performing the same task, you can see that the patient here, the woman here on the left, she doesn't have as much metabolic activity compared to these two volunteers on the right. You can see more orange and red here compared to our patients who did receive chemotherapy. So this is another level of objective evidence that receiving chemotherapy does result or is associated with a decrease in sugar metabolism in the brain, and that seems to be also correlating with those memory problems. Are there any risk factors to developing chemobrains? Because, as I mentioned earlier, not every patient who receive chemotherapy end up reporting chemobrain symptoms, and then the degree and the duration also vary. Many patients report complete resolution of those symptoms. I do have patients who used to perform very complex mathematical work, and I ask them after they finish the chemotherapy, well, how's work is going? And one of them recently told me, I got promoted, I'm doing very well. So they continue to recover quickly and perform very well, while others continue to struggle even years after finishing chemotherapy. So what are the risk factors that are more associated with chemobrain phenomena? And some of those things we really cannot change, particularly when it comes to age, but many of them, they can be addressed by different means. So it has been consistently shown that sleep is very important. A healthy restorative sleep pattern seems to be associated with reduced brain fog symptoms. Stress certainly is also a negative contributing factor, and diet continues to surface as also a major issue, in addition to negative health habits, including smoking and alcohol. Those particular chronic stress signs lead to increase in endogenous steroids, and those seem to have impaired hippocampal regeneration, and that's associated with more symptoms of cognitive decline in chemobrain. There is a term that circulates in the world of neuroscience, and that's brain plasticity. This is a very important and newly recognized term where basically the brain tissue is in flux. It's not static, where what basically we're born with, and as our brain matures in adolescence, things become stagnant, and it's always or only downhill from there. That is not the case. There seem to be continued ability of the brain to change and adapt and grow in terms of function, and even at the anatomic level, regardless of how old we are. So basically, there is an upregulation and downregulation that are competing, and there are things that we can do, as I will share in a little bit, that basically affect that balance. So as we learn new things, go through different experiences, new memories form, and that is healthy for the brain development. On the other hand, damage to the brain, this is the subject of our talk today, from chemotherapy or radiation, certainly that's a negative when it comes to brain plasticity and neurologic function. There are some good things when it comes to brain plasticity. They promote cognitive growth and function, and bad things. And we want to basically limit the bad and augment the good. And those are things that happen to be good anyway for other organs, including the heart, in addition to our focus today, the brain. Exercise comes big here, both aerobic and resistance exercise. So it's I tell my patients, if there is a single thing you can do for your health as you go through chemo, as you get older, is basically to exercise. Diet would be really hand in hand. Excuse me. Maintaining healthy eating habits, Caloric restriction has been advocated by some. I suggest not to do it without consultation with your physician. And then certain dietary supplement, green tea extract, and other supplements, they've also been shown to have positive effects on neuroplasticity. You want to limit fatty food and unhealthy food for you, high saturated fat and sugary diet. Those are negative for brain health. Sleep is very important, and that would be healthy sleep. And sleep deprivation affects the brain function and neuroplasticity negatively. So how can we prevent chemobrain? So during chemotherapy treatment, I really stress to my patients that they really need to focus on their day-to-day health and pay attention to their diet, listen to their body, try to engage in as much physical activity as they can without stressing their body too much. It's already been stressed with chemotherapy. So a phrase I use frequently is just listen to your body. If you feel like taking a walk, please do, but do not push yourself because your reserve will be impacted by the cancer diagnosis and cancer treatment. So get enough rest. That afternoon noon nap may come really handy. Make sure that you're mindful in terms of your diet and number of meals and quantity of food and amount of calories you get in. That'll be very important. In addition, engaging in activities that basically promote the physical health and the mental health of the cancer patient is very important. It's as as I mentioned earlier, there is this balance. The cancer diagnosis, the cancer treatment is impacting this neuroplasticity negatively. You really want to fight back by doing those activities that promote your brain health to try to preserve as much brain function through the cancer fight journey as much as you can. You want to limit alcohol and caffeine. There are some reports that red wine has some antioxidants. You can get that through other foodstuffs, so limiting alcohol would be a net positive for those patients. And then practicing relaxation techniques and meditation many times help. I heard Amy mentioning some of those functions through Gilda's Club. So what else we can do? So what I mentioned earlier here, those are things patients do and families help them do at home. Is there anything that we, doctors and healthcare providers, can do to prevent chemobrain? Certainly avoiding neurotoxins would be a big one. We do not want to deliver or recommend chemotherapy with potential chemobrain to patients unless we expect a net gain in terms of survivorship and quality of life. But there are sometimes, and as our technology improves, there are some treatments that can deliver effective cancer therapy with much less risk of brain damage. So, for example, we can avoid nowadays in some patients delivering whole brain radiation, which used to be the only way we can treat cancer in the brain 20 years ago. But nowadays we can use what we call stereotactic radiosurgery or more focused radiation therapy to the brain that limits damage to brain tissue and prevent manifestations of full-blown cognitive decline from radiation to the brain tissue. Newer also brain technologies include sparing the hippocampus. This is a place strongly impacted in terms of chemobrain because of its memory function and thinking and emotional role. So sparing the hippocampus during brain radiation also can be very positive in terms of reducing or preventing chemobrain manifestations. In terms of drugs, there is really no standard prescription medicine that we, or at least myself, routinely prescribe to my patients. However, there are certain agents out there. Some of them are approved for different indications, and many of the patients were already taking them. They might have a favorable role in terms of preventing or treating chemobrain. There is research ongoing right now to try to answer the question as to whether there actually can be prescribed and FDA approved for that particular indication. We did talk about antioxidants, so those berries are your friend in terms of maintaining neuron and brain health. There's also research exploring anti-inflammatory agents or cytoprotective agents in that regard. In terms of treatment, it really comes down to similar preventive issues. You just try to stress it more after the patients had finished chemotherapy by following an exercise program, using different memory aids. And we have different technologies now that can help with that regard. You can use the apps on your phone or iPad to help deliver certain memory aids or certain exercises that help you relearn those skills that the brain somehow had lost to a certain degree because of the cancer journey. Very important to address fatigue and sleep problems. They will impact negatively the cognitive function. And some patients will need treatment for depression, either by psychotherapy or medications, as this will also negatively impact memory and thinking abilities. Many of the patients have difficulty concentrating, so you want to really minimize distraction and create an environment at work and at home that's really conducive to helping the patient suffering from chemobrain perform their tasks with minimal distraction that can lead to even slowing them down further, and that can lead to frustration and vicious cycles. Cognitive rehab is an important new tool, and there are specialists who have multiple tools to help patients systematically recover their function and achieve those basically changes that are targets to compensate for the impaired neurological symptoms in those patients who have lost them. We want to reestablish it in those patients who they become weakened. You want to strengthen those previously learned patterns. Again, in terms of drug therapy, there are ongoing clinical trials. Many of those trials are run through the NCI, and they include stimulants, which have been shown through some reports to carry some benefits in terms of cancer-related fatigue and chemobrain. Anti-dementia drugs also sometimes help, and neuroprotective multiple agents. This is an antihypertensive agent. This is an antidepressant. This is an anti-inflammatory. Cotinine is present in nicotine. Also, it's being investigated for neuroprotection. Those are not considered standard treatment yet. So I'll conclude with this slide, and then I'll take questions from the audience if there are any. Chemobrain is common. I encounter that every day with my patient, and we have a discussion on how to address it for that particular patient needs. It can happen even in patients who've never had chemotherapy. Cancer diagnosis itself can result in cognitive impairment and chemobrain manifestation. It can last a long time. We need to realize that and listen to our patients' description of what they're going through and try to continue to come up with strategies and means to address it to track it and impact it with therapeutic approaches. We can fight back. I tell my patients there are who are about to experience treatments that are known to be associated with cognitive decline. I warn them up front that this could happen, but there are things we can do to try to prevent it. And those happen to be many times good for us anyway. Exercise, healthy diet, in applicable cases, cognitive rehab exercises, and in some patients, prescription drugs. Thank you for attendance. Thank you for listening to me. I'll stop here and take any questions.